Hi guys, welcome back to my YouTube channel. My name is Victoria, and if you're new here, welcome. This is Victoria's Space, and this is a space where I get to tell people about me, basically, just for you to see me on a brighter note. I film about everything lifestyle and a little bit of nursing. And to my returning subscriber, thank you for always supporting me. I appreciate you and I do not take it for granted. It's been such a long time here. It's been a lot has happened, a lot is still happening, but I'm just glad to be back. Anyway, last week I celebrated my 2 years anniversary in the UK. I mean, that's such a good news, isn't it? I've been practicing for a full 2 years in the UK. It's been such a roller coaster kind of journey, I'm not going to lie, but I'm just grateful to God for protecting me, protecting my pin, most especially protecting my finances, and protecting my job. Those are the things that I'm actually grateful for, and I'm just so glad for everyone that has supported me from the day one that I got into the UK till this present time. God bless you all. So judging by the title of this video today, I am going to be giving you guys important tips on how to properly take over and hand over. So this video is based or is majorly for nurses. It's peculiar to nurses. This video is majorly for nurses, and I'm just trying to drop a little information to people who are aspiring to be UK RNs, or you want to move to the UK soon and probably obtain a master's in nursing, after which you would practice. This would also be helpful to student nurses who are looking into starting nursing soon, fully. So if you think that you're going to be interested in this kind of video, please do not forget to like, to comment, share, subscribe, turn on your post notification anytime, and keep watching till the end of the video. So let's get right into the purpose of this video. So like I said, I am a registered nurse in the UK, and I have been practicing for full 2 years. I practiced in Nigeria for a year before I moved down to the UK. So my total practice here has been 3, but 2 years in the UK, and I have seen, at least for those 2 years, I think I have seen a lot. I have handed over a number of times, a lot of times actually. I have taken over from people a number of times. So I just wanted to share the little information that I have, gain a little knowledge that I feel like would be helpful to people who are looking into starting their career in nursing or are almost done as student nurses. So the first thing I would like to say is that before your handover or takeover process, the nurse in charge, that's the NIC of your shift. So for each shift in the UK, you have to have like set of nurses, of staff nurses, and then you have to have a particular nurse in charge. That's one person who is a senior band. Meanwhile, I got a charge nurse role. I got a band 6 role. I did, and I'm moving to my dream city. So I'm leaving the current city I am to my dream city. God is faithful, yeah. So I moved from being a staff nurse to being a sister. Yeah. Let me just say that again. Yeah, so before we go into the video, this is just to create a disclaimer that any patient's condition or whatever used in this video is being made up and not the actual scenario, or like not the actual situation. Please, we would not be mentioning patient's name or patient's condition or anything here. So anything that has been said in this video is not true and is a disclaimer, especially when it regards to patient. But take good notes, or make good use of the knowledge that I've been able to put out there. So yeah, you would usually have like a nurse in charge. So the charge nurse is the one who actually like oversees the shift. They ensure proper allocation of staff. They ensure that there's smooth running of the unit throughout the shift. So the nurse in charge would have given the previous nurse in charge, probably you're doing a day shift, the nurse in charge from the night shift would give like a general handover to everybody taking over the shifts. So like you all just gather at, like in my unit now, we don't have like a specific room where we do that. We all just gather at the reception, and then they just tell us about every patient in the unit. Mind you, you're not looking after every patient, but technically you're looking after every patient, if that makes sense, because you're responsible for your patients, right? So you're just looking after 6 patients or 8 patients. In my unit, we take just 6 patients. Some hospitals, they take as high as 8, some take just 4. So it depends on your luck, and it depends on how busy your shift is or how well staffed you guys are, if that makes sense. So the moment you're done with the general handover, the nurse in charge must have told you guys about the acuity of the ward. Probably you have patients with high news, low news, or something, they would have told you that. So you're going into your bay with the mindset that you're receiving your own 6 patients, and still at the back of your mind that you're taking care of other patients, if that makes sense. So the way the UK build their wards is that, in Nigeria we just have like a general ward. If you're in the male surgical ward in Nigeria, it's just like a general ward where you have like 28 to 32 patients or even more in a whole space. Whereas in the UK there's like a full ward like that, like the ward is that full, but then they are divided into bays. So a bay is like a room that contains patients. So we have bay 1, bay 2, bay 3, bay 4, bay 5, bay 6. It depends on how big your unit is. So in bay 1 there are 6 patients, in bay 2 6, 7, you get. So you have just 6 patients yourself. So if you are allocated to bay 1, then you're working with the 6 patients in bay 1. So you're directly responsible for those 6 patients. Whatever happens to them is on you and your assistant, if that makes sense. So whilst you're taking over from your day team or night team, depending on what shift you're doing, these are the important information you should pay attention to, or you should take note of. Number 1, of course, you want to know the name of your patient. You want to know their date of birth. You want to know, just their name, and just in general like information. You want to know their name, their age, and their date of birth, which is very important. Those 3 things are the things that you should ask. So what is this patient name? This is this patient name. They will tell you, and then you have an idea of what you register it in your mind, and this is what your patient's name is. Secondly, you want to ask for the reason for the admission. Note, this is a side note, or like this is an information that I'm just trying to share. There's a difference between reasons why your patient is being admitted and why they are currently on your ward. A patient could come in with shortness of breath, and you might be managing them for COPD. Yes. So when they say reason for admission, we're not talking about the impression of the doctors. We're not talking about the diagnosis at that time. We're not talking about the risk that has been identified. We're talking majorly on why did this patient come in. It's just, for example, if I am sick and I go to this hospital and I say, oh, I've got a migraine, I think I have a headache, and I have fever. At the end of the day, by the time the doctors will diagnose me, they might think I have a meningitis or something. Do you understand? So reason for admission is, why did this patient come in? Oh, this patient came in for shortness of breath. Then you move to the diagnosis. Oh, this patient is being treated for type 2 respiratory failure. Oh, this patient is being treated for COPD. After which you must have asked the reason for the admission. The next thing you want to ask is any background medical history, any significant past medical history that this patient has. Does this patient has any past medical history that you should know of? The past medical histories that I pay attention to the most, I'm just going to list them, is number 1, diabetes, because you want to regularly check their blood glucose to be sure that they are not hypo or hyperglycemic. I pay attention to that a lot. Does this patient have previous history of PE? That's pulmonary embolism, because you just have to know, what PE does to the body. I don't have to be going deep into that right now. That's not the purpose of this video. PE, you also want to know if this patient has history of heart failure or kidney failure, so that you would know whether or not they're on fluid restriction, input and output, all those things. So you want to know the major, past medical histories that you have to. Also, another important past medical history is probably your patient has like anything related to their mental health. You have to take account into that as well. So once you must have asked about the past medical history, the next thing you want to do is ask about this patient's news score. So our news score is more like an observation tool that we use in the UK. So once you're done, taking vital signs from your patient, which is the temperature, your pulse, your heart rate, your pulse, your resp, your pain levels, you've taken the SAT level and all those things, the system kind of sums it up. So anything more than 5 in Anything more than 5 is danger. That's what, yeah. So it's high news, and you have to escalate that. Whilst if you have just three in single parameter, that's also for you to escalate. For example, if you've got a patient, we all know like the normal heart rate is from like 60s to 100s maybe, and if you now have a patient that is already like, you know, having high heart rate of maybe 130s, that's being tachycardic, right? The patient has tachycardia, so you have to escalate that. That's 3 in 1 parameter, so you have to escalate it. After which you must have asked about the new score. If God be for you, maybe you have a patient musing of 0, that means the patient is stable and fine, and you just need to keep monitoring them. So the next thing you want to ask is the mobility status of this patient. Is this patient mobile? Are they able to move from their bed to the toilet, or they use the commode by the bedside, or are they completely bed bound? Is this patient chair bound? You want to know, so as to be able to help the patient. So by the time the patient needs the loo, you don't have to say, oh, but I was told that you can use the toilet, how come you can't? Or I assumed that you can use the toilet, how come you can't? You know, that would sound really disrespectful to your patient. So just know this, so that by the time you already know this information, you know, you don't have to bother your patient about it. You already know they are bed bound, just for you to give them bed pan or like pads and all those things. So yeah, mobility status of the patient is extremely important. Another important thing to note or to ask is the skin condition of this patient. So here in the UK, we pay attention to skin conditions a lot. So in case you have a patient that has ulcers, cellulitis, you know, pressure sores or anything, please say them to the nurse taking over from you, or mention it when you are receiving an handover, or when you're, you know, taking over. Basically, it's confusing, yeah. So make sure you let them know the skin condition of this patient. Okay, this patient has a bilateral leg cellulitis. Okay, this patient has ulcers, this patient has gangrene. You know, just mention those things so the nurse taking over from you is aware. Another thing you have to ask is this patient oriented, alert, or confused, or semi-conscious, or conscious? You know, you just have to ask, and make sure that you even look around to be sure that you're receiving, like, you know, conscious patient. That's actually one, that should be number one. Like, make sure that your patient is fully conscious, all of them. Don't receive a dead patient from another nurse. So you have to ask, oh, is this is bed one oriented and alert? Do they know where they are they confused? You know, just ask, so you know how best to relate with your patient, so you don't go about talking to a confused patient like they're oriented, and you know, you begin to make them feel bad, because we're trying to prioritize patient's care in it. So the next thing you want to do after confirming that this patient is alert or confused or anything like that is also ask about how they ventilate. Is this patient ventilating on room air, like normal air that we breathe, like this, the one I am breathing, or does this patient have to ventilate with the aid of an oxygen, or do they ventilate, you know, using, I don't know. Well, I work on the ward, so we basically ventilate on room air and oxygen. ICU. This video is not for ICU people, because I've never worked on ICU. So I don't know how you guys do your handover. I know it's more intense, yeah. So you have to ask if this patient is on oxygen. If this patient is not on oxygen, you have to pay attention, and it could be that they are using nasal cannulas or venturi marks, or you know, non-rebreathing. Then the method you're using to deliver the oxygen, do you get, like, are you using a nasal cannula? Are you using a venturi max? Are you using a non-rebreathing? Is this patient on nebulizers? That's also important. Is this patient being nebulized regularly? So you also have to ask. Another thing that you have to pay attention to or take note of is the kind of medications this patient is on, and also the fluid intake and output. So when I say medications, I mean in cases where you have patients that are hypertensive, you have to be extremely careful about the kind of medications that you're giving to this patient, because, for example, a patient who is hypertensive might be on furosemide, and maybe before you start your medication rounds in the morning, maybe you're not the person that likes to check observations, and maybe you just use the previous shift, what they've done, like the previous, because the previous shift would have done an observation by around 7, and you're taking over around 7:30, right? So you have to make sure that this patient is not hypotensive before you give that furosemide. In a case where you have a patient on digoxin, you know what to do. Check the pulse, make sure that it's higher than 60 or like 60, not below 60 anyways. So if you've taken note of these things, you know, you'll be practicing really safe. and you will not do what you're not supposed to do. And yeah, that's it. Fluid intake and output, make sure that you pay attention to that as well. Is this patient on fluid output or intake? Is this patient on any fluid restriction, like I mentioned in case of heart failure, like, you know, probably if this patient has pulmonary edema or something, you have to make sure that you're calculating their fluid, asking the previous shift did it, you know, and also take account into that. Another thing that you have to pay attention into when you're taking over or handing over whatsoever is the cannulas. I know a lot of people do not pay attention to cannulas, but I once had an incident, not me directly, and since then I've been taking, you know, full consideration into making sure the cannulas are fine, because sometimes your patient could already develop like extravasation from you giving a lot of IVs or fluids and you're not even noticing, especially for patients that are confused where you have to bandage the cannula around them just so they don't pull it out. My dear, if you're not very careful, the harm is going to get swollen and the medication will be left in the body. Like, okay, yeah, in the spaces. So you don't want to do that. Do you get my point? So you have to ask about that. I don't think I'm missing out on any other thing. Actually, I'm just trying to think about it to be sure that I'm not missing out on anything, because I'm trying to make this as detailed as possible for you guys. Another thing you want to ask, yes, is the investigations that this patient has done or pending investigations. So we normally, the routine admission process includes chest x-ray, but sometimes you come in with, you have patients that have like abdominal pain, or patients that needs to go for an endoscopy, or you have patients that have fracture and you know they need to go like for x-ray. So you have to ask, so has this patient had hip fracture, hip x-ray or not? Has this patient had an endoscopy done for, probably they have upper GI bleed or something? You know, you just want to ask that questions so that you are aware, so that by the time they come to you and say, oh, your patient is booked for CT scan, you're not shocked. Or your patient is going down for MRI, it's not coming to you as a shock, like, oh really, I didn't know that, oh, I'm not aware. No, you don't want to do that to yourself. That would look really mid. So, you know, just pay attention to this. Another important thing that I forgot to mention at the beginning of this video is the infection status of your patient. You have to be very, very, very cautious, because sometimes you might be taking over COVID patients and you don't even know, and there are patients that do not have COVID in that same day. So make sure you ask their COVID status. Does this patient have COVID or not? Is this patient having diarrhea or vomiting? Have they had any episode of diarrhea or vomiting? Do you get my point? Like, just take note of these things and, you know, put them to good use. And I think those are basically the major things that you need to know, aside from reading the patient's notes to, you know, get in-depth information about this patient, and also being able to care for them the right way. Do you get my point? So also, in addition, I forgot to mention that you have to ask if this patient is able to swallow, eat, and drink, you know, the proper way. So because we have patients that sometimes they're on peg feed, NG tube, and all that, whereas we have patients that can swallow by themselves. So you have to be very cautious. You know, you don't give to somebody, you don't go to patients with peg and then start trying to make them take their medications orally. Do you get my point? So make sure that you ask, was this patient on peg feed? Have they been using their medications via the peg or via the NG tube? Do you think that I can give them orally? Have you been giving orally? Has this patient been tolerating, like, you know, orally? How is the swallowing? Is it going on smoothly? You know, all that you have to ask. And that's majorly everything that you need to know. You can take the rest of the information that you need from this patient's notes. I know that the way I'm speaking, it appears to be very long, but when you're used to taking over and handing over, I promise you, it's like it happens in like minutes, like 10 minutes, you're done. And handover is supposed to take like 30 minutes. But because you're already used to, you already know the things that you want to say in your head. Do you get? You don't have to be, you know, going back and forth. So you just give it directly and then go through over it with all your patients. I know that this is not the video, this video is not, you know, for every department. That's why I said it is peculiar to the kind of practice that I'm in. Like, I currently work as a medical nurse, so I'm talking based on treating or caring for medical patients. So in case you work in a surgical department, I feel like there are a little bit of difference. The surgical department pay a lot of attention into their fluid balance or fluid intake and output, because, you know, they're dealing with patients with medical conditions with surgical conditions. So they might also pay attention into wound care. We also have wound care on medicals, but it's not as rampant as it is on surgical ward. You know, they have to take care of surgical sites and all that. So I don't know, I've not really worked on, like, I've only worked once or twice on the surgical department before, and it was a night shift. So yeah, just pay attention to the information that you need. And if you're an IC nurse, don't even watch this video, because I see people on another level of handover. Like their own handover is like extremely intense. They go in depth with ABGs, you know, they talk about acidosis and all those things. We do that on the wards too, but that's when we have critically ill patients, you know, and we have the outreach team, that's the critical care team around to help. So it's not all on you. You have people that you can always bank on in case the matter is becoming super complicated than you can handle. Okay, I forgot to mention this last point. I don't know, things just keep coming. This is for you to know that it's plenty inside my head. Is this patient on cardiac monitor, or this patient needs cardiac monitor? In case you have patients with cardiac syncope, or you have patients that are on some certain type of medications like, you know, magnesium sulfate, calcium, medications that can affect the heart. Actually, potassium, you have to make sure that you place these patients on cardiac monitors. Yes. And in case you have a patient with high heart rate, you know, this patient came in with chest pain, have they had ECGs done, have they had their troponin level sent, and all those things, ask. If a patient comes in with chest pain and they're not cardiac monitor, ask the nurse to put them on one before she leaves and document it. Ask the nurse if this patient has had their trops done. What are the trop level? What's the first, second, or third trop? Does this patient needs ACS treatment, or have they had ACS treatment? You know, these are basic things that I don't want to go into deep, you know, details. These details you can always get them on the ward. And also, do not forget that if you have a patient with sores on their back, on their bum, use a pressure pump. Please do. If there was none during the previous shift, by your own shift, put there and document it. You know, we're all trying to protect our pins and, you know, trying to give the best care that we can to our patients. I hope that somebody somewhere finds this video very helpful, and I hope that I will be able to make this kind of videos, you know, the more. And you know, you guys, thank you so much for tuning in. I really appreciate you, and I hope to see you guys next time on this same channel. Until then, I remain your favorite nurse, Victoria the nurse. Thank you.